Yeah, so I think there are three aspects that are highly relevant. So we have CRS and ICANS. These are the topics that have been talked about a lot. And as a novel aspect, we have the long-term cytopenias that are getting increasing awareness as we have patients at long-term follow-up. I think in the CRS setting, most centers are now very experienced, and we are less challenged by CRS. But also, if we think of treating patients in an outpatient setting, this is still a very valid topic. And I think there's interesting data that prophylactic Tocilizumab and early steroids might alleviate severe CRS. But I still think at this time point, we are not completely aware if the patients that were treated in these early interventional prophylactic toxicity trials, are they actually the same patient cohort? So I think this is a very interesting development, but I still a bit cautious to translate this into everyday practice at this time point. Second aspect, neurotoxicity. I think this is still somehow a black box for a lot of us, and it's still very challenging if it occurs. So there are interesting aspects like a GM-CSF directed antibody in clinical trial, also given prophylactically. But I think at this point, we have no real novel insight how to deal with it, except detect it early, monitor closely, and intervene with steroids. And I think the most evolving data is coming from the cytopenias. So we also reported, and from our data from the University of Munich in collaboration with the University of Tübingen and University of Hamburg, that there is prolonged cytopenia in over 80% of the patients, and that we have some patients who have very prolonged cytopenias over going 40 days, in which we also have used already successful autologous stem cell transplant, as we luckily had those from prior treatment lines. But I think at the current time point, also looking at the data from others, from Locke et al., showing that we also have prolonged CD4 lymphocytopenia, and we also have prolonged hypogammaglobulinemia, one has to be aware that we have to do thorough monitoring and use prophylactic antibiotics, antiviral and antifungal prophylaxis, and in some cases also immune globulin substitution in these patients. And I think we are developing guidelines in particularly for antifungal prophylaxis. And here I think the data is clear that additional application of steroids makes these patients in particularly at high risk for opportunistic infections. But these data are evolving, and I think currently we can clearly say, please be aware, watch these patients closely, and apply prophylaxis treatments in these patients.